Hello, my name is John Moyer, and I want to welcome you to the NIH Office of Disease Prevention's Mind the Gap webinar series. This series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods and to support the development of better methods. Before we begin, I have some housekeeping items. You can submit questions during the webinar via the chat pod. You'll need to open the pod by hovering your cursor at the bottom of the Zoom window and then clicking on the chat icon. Please direct your questions to hosts and panelists. We will open the floor to questions that have been submitted via the Zoom chat pod at the conclusion of today's talk. The slides and video recording will be posted on our website, prevention.nih.gov/mindthegap, in approximately 2 weeks. Lastly, we would appreciate your feedback about today's webinar. Upon closing, you will be asked to complete an evaluation. We would appreciate your feedback as it will help us improve this webinar series. At this time, I'd like to introduce today's speaker, Dr. Renad Baitis. Dr. Baitis is Chair and Ralph Seal Paffenbarger Professor of Medical Social Sciences at the Feinberg School of Medicine at Northwestern University. Her research leverages insights from implementation science and behavioral economics to make it easier for clinicians, leaders, and organizations to improve the quality and equity of care and to enhance health outcomes using best practices. Dr. Baitis' research interests include mental health, firearm safety promotion, cancer, HIV, and cardiovascular disease, and she collaborates closely with key partners including patients, clinicians, health system leaders, payers, and policymakers. Dr. Baitis is an international leader in implementation science, having published hundreds of articles in this area. She has led 2 NIH Centers on Behavioral Economics and Implementation Science, and she has served as principal or multiple principal investigator on 11 NIH grants. She's an associate editor for Implementation Science and Implementation Science Communications, the flagship journals for the field. It is my pleasure to welcome Dr. Baitis.
Thank you so much for that very kind introduction. I'm so excited to be here today on the Mind the Gap webinar series and to be joining this community and sharing some of the thoughts and insights from the work that our team has been doing over the past few years. So I want to start by acknowledging the incredible team of folks who have really contributed to the thinking that I'll be sharing with you all today in bridging 2 really important fields focused on human behavior change: implementation science and behavioral economics. And this was very much work done in partnership with the folks that you see pictured here, as well as funding from both the National Institute of Mental Health and the National Cancer Institute. And through the course of this talk, I'll be sharing lots of different examples reflecting the work of many different teams. And so I just want to call out how important it is to have interdisciplinary teams come together to make magic to advance the science. So in our time together today, I'll be covering 4 broad chapters. First, I'll start by introducing a little bit about what implementation science is as a discipline, and then I'll talk a bit about behavioral economics and what it might add to looking at the world through an implementation science lens. Then I'll share some exemplars from our team and other teams doing this work at the intersection or nexus of implementation science and behavioral economics, and cover some implications and future directions. And I hope that this makes this community really excited about these methods and approaches, and that this will contribute to your thinking in the great and impactful work that you're all leading. So I'll start with implementation science. And as I dive into implementation science, I just want to start with a positionality statement, because my identities and my lived experiences greatly shape my perspective and ignite my enthusiasm about why I think implementation science is a valuable tool for us. So you can see pictured here some of my various identities. I'm a Middle Eastern immigrant. I identify as a woman. I'm an implementation scientist. I'm a PhD clinical psychologist. And I see implementation science as a way to advocate and amplify the needs of our communities in pursuit of achieving population health and social justice at scale. I want to argue, coming from that lens that I just shared as an implementation science, that closing the gap between discovery and implementation may very well be one of the most meaningful or grandest challenges of our time. We spend millions, billions of dollars on discovery, but we spend very little attention thinking about how to actually implement and get those discoveries out to everyone. You can see on the left here an editorial that was published in Science that by my colleagues, Dr. Enola Proctor and Dr. Elvin Geng, during the COVID pandemic, calling for a new lane for science, arguing that COVID-19 has shown the world that knowing what to do does not ensure doing what we know. On the right, you can see an influential simulation piece that was published prior to the emergency use authorization of vaccines during the COVID-19 pandemic. And what that paper showed was that the implementation factors would be more important in looking at the effectiveness of the vaccine than the biological components of that vaccine. And so I think these together make the case that implementation science has a lot to offer, and when left off the table in very high stakes situations, it's problematic. So I've said the word implementation science probably already 50 times, and I think it's important as scientists to define what we mean. I want to first share my personal definition of implementation science, which is about making sure that all people are getting the things that work in the community writ large and moving the needle equitably in health. I also want to share the National Cancer Institute definition of implementation science, so we have a more formal textbook definition. The study of methods to promote the adoption and integration of various things, whether they be evidence-based practices, interventions, prevention efforts, policies, into routine healthcare and public health settings and the community to improve population health. So there's a lot wrapped up in that, and I'm going to try to unpack this a little bit. But you can see at the bottom the 7 Ps, which illustrates the types of things that we might want to be studying within the context of implementation science. The work under the umbrella of implementation science has its own assumptions and foci, and I think it's helpful to share them so that we're all on the same page. The first is that the work must be done in partnership with our community. The whole premise of implementation science is that if we co-create and we partner with our communities way up the chain in the process of discovery, we'll be much more likely to develop things that can then be implemented and found acceptable by folks in the community, whether it's the people delivering the thing or the people receiving the thing. But this work really cannot be done in the absence of deep partnership and ensuring that the things that we're implementing are actually priorities to our community partners. Second, the outcomes that we focus on are different from traditional studies in biomedical research. So we focus broadly on clinician, and I'm using that as a broad term, but it basically refers to anyone who might be delivering a prevention or intervention approach that we want to implement. So clinician behavior within organizational constraints, because we all know that people are operating within a broader environment that shapes their behavior. So that's different from traditional biomedical studies that tend to focus on patient health outcomes within the context of prevention or intervention efforts. Third, context is not seen as a nuisance. And so when we're doing multi-site studies, which is how we do implementation trials, our ends are at the organizational level or the unit level. We don't see context as a problem. We seek to understand it and to look at the association between contextual factors and our implementation outcomes, as well as target our strategies to help people do the thing at those contextual factors that might make it harder or easier to implement. Typically, we're looking for there already to be evidence for the thing that we're trying to do at scale, because we don't want to be spending a lot of resources and time trying to implement something that may not ultimately work. I can say more about that in the Q&A. This type of thinking should absolutely be infused earlier on in the scientific process, but typically when we get to our kind of large-scale implementation trials, we like to know that there's some evidence for the thing that we're trying to implement. And we have specific frameworks, methods, and strategies that can be brought to bear within the context of this work. I could spend this whole hour just talking about implementation science, but I'm not going to, because I have some additional thoughts about how to enhance approaches in implementation science. But I'm happy to answer any questions that people have, and I've shared resources of key readings in implementation science if you're interested in doing a deep dive on the field. I want to share this language with you from my colleague, Dr. Jeff Curran, who wrote this piece in Implementation Science Communications called Making Implementation Science More Simple, because we do have a lot of jargon. So when you think about the field, there's some very non-scientific language that can help us all be on the same page. And you might have already noticed that I've used the word thing far more than you would expect to hear in a scientific presentation. And this is why. So whatever the intervention, the practice, the innovation is the thing. That's what we're trying to help people do. Typically in medical research, effectiveness research is looking at whether the thing works in the real world delivered by clinicians. Implementation research looks at how best to help people or places do that thing. And the strategies are the stuff that we do to try to help people or places do the thing. So it's really meta and it's up a level. And so our studies really tend to focus on different strategies to support people and places in doing the thing well. And then often we also measure outcomes related to the targets of the thing, the end users, the people who are meant to receive it. So hopefully that helps clear up some misconceptions or helps articulate better what implementation science is. And you'll see some examples as we walk through this presentation that will hopefully bring this to life. But I want you all, as you're listening, to be thinking, what's my thing? And what are the strategies that I might use to help people do that thing based on what might make it harder or easier for them in their context, whether that's factors about the people themselves who might be delivering the thing or the setting that they work in. And so I also like to start talks with the main takeaway so that people can kind of have it in mind as they are listening. And so the main takeaway from this talk today is that the nexus of behavioral economics and implementation science has the potential to transform the seemingly intractable challenge of moving the needle in healthcare equitably, which, as you remember, is my own personal definition of what implementation science is. So you might ask, how did I become interested in this intersection of behavioral economics and implementation science as somebody who shared as my identity is really as an implementation scientist? So I had two key insights over the course of my career so far that really helped shape me in doing work in this direction. The first is related to deeply partnered work that I had the great fortune of doing in the city of Philadelphia with the Department of Behavioral Health and the network of over 100 clinics that serve children and families within the context of the public behavioral health system in the city of Philadelphia. And I was doing a lot of observational embedded work within those clinics, meeting with clinicians, meeting with young people and their families, trying to understand how a system supports the implementation of a particular set of evidence-based practices for people struggling with mental health difficulties. And as I spent all of this time embedded within the community mental health context, I saw clinicians who were trying to do the best that they could within their organizations, and that they really struggled with adding on these complex evidence-based practices to their behavioral repertoire. And so as I watched this, I started to wonder if there were ways to make it easier for clinicians to deliver evidence-based care, because it felt to me at times that we were actually making their job harder. You can see on the right here some work that we published led by my colleague, Dr. Becca Stewart, talking about Maslow's hierarchy for community mental health clinics. And that many of the clinics we were working with were just worried about keeping the lights on, staying compliant with regulations, and that delivering evidence-based practices was kind of at the top of that hierarchy, like self-actualization. I just want to bring this point to light. This was a newspaper headline coming after one of the studies that we did in collaboration with the city of Philadelphia, describing slow change, despite all of these things that we were doing to support clinicians and organizations in delivering high quality care. And so this really brought about a bit of an existential crisis for me as I thought about how we might continue to improve our efforts to implement evidence-based practices in ways that would support clinicians and organizations. My second key insight came because I had the great fortune of partnering with incredible colleagues who were experts in behavioral economics. And we were able to do that through two P50 infrastructure grants, one in mental health and one in cancer, that really brought together interdisciplinary teams to solve this seemingly intractable problem. While I was at the University of Pennsylvania, which was my institution prior to coming to Northwestern, I also had the great fortune of becoming the second director of the Penn Medicine Nudge Unit, which is the first behavioral design team embedded within a health system, bringing insights from behavioral economics to the bedside within the healthcare delivery system. So this opportunity really allowed me to go deep into what behavioral economics is and to think deeply about how to bring these insights into implementation science. I want to bring to light what behavioral economics is now, just like I defined what implementation science is. And I want to start by clearing up a common misconception. If we were all in the room together, or if I put in the chat, what do you think behavioral economics is? There'd be a wide range of responses in terms of what people think it is. And many people actually think of it as being all about paying people to do the things that you want them to do, or financial incentives. That's actually not accurate. And so I'm going to tell you all about why that's not the case, but I want you to just kind of plant that seed, and I'm going to illustrate for you what the theories and approaches within behavioral economics bring to the table with a couple of pictures from outside the healthcare setting. So what you see here is a subway station in Stockholm, and this was part of an ad campaign done by a car agency. But in 2009, they painted the steps so that they looked like a piano. And basically what they were able to show is that during a one-day test, after painting the steps in this manner, people were 66% more likely to choose the stairs over the escalator, given this change in the choice architecture is the wording, or the environment. So the environment really shaped a person's decision to take the stairs, which is a health behavior if somebody's able-bodied and able to do that. Here's another favorite example of mine. I'm gonna go ahead and zoom in on this little picture here because you may not be able to see it in the presentation. This is a urinal, and that is a picture of a fly. And these flies were placed in urinals in public bathrooms to make it easier for individuals who are using the urinals to keep them clean, reducing spillage by a large percentage. So again, you can see here how a small change to the environment changed behavior. Here's another example from London. Here, smokers are encouraged not to litter by asking them to vote with their cigarettes on who the best player, soccer player, or football player in the world is, Ronaldo or Messi. An evaluation of this approach suggests that this reduces litter by up to 46%. So again, you can see here how a change in the environment changes behavior in a simple way. The last example I'll give you is a digital nudging example. If you've ever gotten stuck in a session on Netflix where you just keep watching the next and the next and the next, it's because the default is to go on to the next video, right? It doesn't ask you if you want to continue, it just automatically continues. So it's nudging you to continue watching. So these are all just examples that I am sharing with you all in order to help you think, okay, now I can see how these concepts might be brought to bear within implementation science to make it easier for clinicians and organizations in healthcare and community settings. And that was really the kind of like basis of this idea of the work that I'll be sharing, is really bringing together these two disciplines that really developed very differently with different founders and groups of individuals doing work within the space. This slide is kind of a helpful way to understand the evolution of how we understand behavior. And as a reminder, both implementation science and behavioral economics are focused on human behavior change within environments. So early on, when we thought about behavior change, we thought about the fact that people don't know how to make the best decisions, or they might not have knowledge. And so if we want to change behavior, we tell people you should do X, Y, and Z. We all know that approach typically does not result in robust behavior change. The second wave or kind of 2.0 of thinking around how to change behavior comes from the standard economic model. And this is the idea that people are fully rational, meaning that they maximize utility in every decision that they make, and that they have complete insight into how they make decisions over the course of the day. And remember, we're making hundreds and thousands of decisions over the course of the day. So what matches up with that, if you're thinking about strategies to support behavior change, is to give rewards or financial incentives. Now, remember, that's not behavioral economics. That's actually a standard model of thinking about how behavior and decisions are made. The third kind of wave of how we think about behavior comes from behavioral economics, and is based upon this idea that we behave as humans in predictable ways due to the understandable and knowable patterns in how we make decisions and how we react to our environment and our context. And so if we want to change behavior, we can harness those knowable ways that guide our decision making and or restructure the environment, like that urinal or that subway staircase that I showed you, to make it easier for people to engage in the desired behavior. So implementation science, I would argue, is kind of at the 2.0 place right now. We have made a lot of assumptions about trying to support people in changing behavior that are more aligned with the standard economic model. And I'd like to see us start moving into the behavioral economic way of thinking and bringing that to bear in how we try to support clinicians and organizations in changing their behavior. And so what all that means, said another way, is that we should design our science less for the ideals of human behavior and more for the reality of human behavior. And that's where we'll be able to have more effective behavior change. And this is consistent with bounded rationality and dual process theory, for those of you all who want to better understand the mechanisms behind this. We have incomplete information, we have enormous constraints on time and resources, and thus we employ these knowable and predictable thinking patterns to make decisions, because otherwise our days would be completely overwhelming. And we can use those patterns to help us think about how to make more effective implementation strategies, or supercharging them. And remember, those strategies are the things that we do to help people do the thing. Just in case, it would be helpful to have a little bit of data or evidence that clinicians are human and use the same kind of thinking patterns that we see in the broader population. I want to share this study that came out of the Penn Medicine Nudge Unit several years ago. What you see here on the x-axis is primary care visit appointment time, and on the y-axis you see the patients eligible for breast cancer screening. The blue line are the number of orders made by clinicians for screening. The orange line are patients' completion of those orders. What you see, which is a very knowable pattern that we see across all kinds of professions, is that over the course of the day, clinicians order fewer breast cancer screenings and patient complete fewer breast cancer screenings. And those are likely due to decision fatigue and falling behind over the course of the day. This is a study that provides great evidence for the idea of changing the default, which is kind of a core principle that has been gleaned over the past few decades in behavioral economic work to shape behavior. So this was a study led by Dr. Mitesh Patel, who was the first director of the Penn Medicine Nudge Unit. And what you see on the x-axis are dates, and on the y-axis is the percentage of medications in a health system, across a health system, that are ordered as generic. What happened right in the middle of this graph is that the default in the electronic health record that they used in that health system changed from being name brand to generic. Prior to that change, you see a lot of heterogeneity in how clinicians prescribe medication. And following that change, you see a remarkable result where people really stay with the default, which is a finding from the behavioral economics literature, with the exception of a drug that clinicians prefer the name brand formulation for, which is Synthroid. And I can't promise that every study that we do, I can actually promise you that every study that we do is not going to look like this. However, this is a really nice example of how leveraging those insights from behavioral economics can help us think about how to support clinicians in a way that makes it easier for them to do the desired behavior rather than making it more difficult. Okay, so hopefully by now you feel like you have a good handle on what implementation science is, and you have a good handle on what behavioral economics is, and hopefully you're even starting to see kind of the Venn diagram and understanding how the two fit together as two disciplines really focus on thinking about how to optimize supports to engage in behavior change. Now I'm going to give you a couple of examples from work that I've either collaborated on or led to really bring this to life. So I've bucketed, I like fours, I guess. I've bucketed the exemplars for infusing behavioral economic principles into implementation science work into these 4 categories. So first, I'll talk a little bit about using these principles to do innovative design and to leverage participatory approaches to these studies. And then I'll share 3 sets of studies that each use behavioral economics targeting different constituents. So nudges that target clinicians, and then nudges that target both clinicians and patients. And then the final example I'll give you will be a study where we look at both combining nudges with more traditional approaches from implementation science. So hopefully this will give you a really good sense of what this work looks like. So I do want to call out some principles for strategy design that come directly from the behavioral economics literature. And a really nice way to think about this comes from the behavioral insights team, and it's called the EAST framework. And EAST stands for easy, attractive, social, and timely. And essentially what you want to be doing when you're designing either things or interventions or implementation strategies is leveraging these principles from the EAST framework. So here are a couple of examples. We always want to try to make it easier for people to do a particular action. So we want to look at the workflow and how to engage in that behavior and try to get rid of steps and simplify it and get rid of sludge, which are the things that we have to do that make it harder to get to an end goal. So the example that I gave you about the default in the electronic health record is a really good one. We made it easy for clinicians to prescribe generic medications by making it the default. Attractive. So we really want to make sure that when we're asking someone to make a decision about a behavior, that we make it easy for them to see and know what the best choice is using colors, bold text, or personalization. So for example, if you're sending a message through the electronic health record through a best practice alert, although I don't recommend that you do a lot of best practice alerts, but that could be a conversation for the Q&A as well. You want to highlight the main information, and you want to make sure there's not a lot of extra information that makes it hard for people to follow along. Making things social is thinking about how to leverage social networks to create peer pressure or support around the desired behavior. So for example, emphasizing competition with peers encourages people to walk more, or gamifying it and having a community of others who are all trying to hit particular targets. And then finally, the concept of timeliness. So we want to think about when people are most receptive to receiving information. So one of the studies I'll share with you all is around sending a nudge or a message to patients and clinicians to have a serious illness conversation right before the appointment. That can boost completion rates of that versus if somebody were to get it after the appointment or a week before. And I'll tell you more about what I mean by that when we get to that. Fog behavior model is a helpful model to think about and gives insights on when solutions from behavioral economics might be the most useful in intervention design and in implementation strategy design. So the argument here is that behavior change requires a combination of motivation, ability, and prompts, right? And so when nudges or behavioral economic solutions work the best is when people want to make the change, when they're able to make the change because it's easy to do it, and they might forget or they need a little reminder. That prompt comes in and makes it easy for them to do the desired behavior. So I think it's important to remember that when these conditions aren't met, a nudge might not be the solution. And I'll say this at the end, but I want to say it a couple of times during this talk, that this is not the be all end all of all solutions. This is one aspect to design and thinking that you want to engage in when you're doing prevention, intervention science, implementation science. But it's necessary, but it's not sufficient. So it's not going to be the panacea to all behavior change. I want to share with you the nudge ladder. So this gives you a sense of the types of principles and approaches that are leveraged by using this lens. And what we find is as you go up the ladder, the components are more potent. So we know from the literature, and actually there was just the National Academies report published just this year on behavioral economic approaches, that defaults, and I've already kind of described that to you, so making the desired behavior the defaults, and simplifying are really the strongest, most potent approaches we have to draw upon into our implementation toolkit. So I've talked a bit in this section about design thinking and how we think about bringing these behavioral economic principles to designing our implementation strategies. This is a technique that we like to use to help us de-risk our implementation strategies using prospective bias, which is a type of thinking pattern that we engage in. And so a pre-mortem is actually the opposite of a post-mortem, which you may have heard of. So at the beginning of a project, as a team and with your constituents and partners, because this all has to be partnered work, you would sit down and you would think about you would pretend that the project had failed. And then you would use prospective bias to start thinking about what the factors were that could have caused that failure. And then come up with strategies to avoid that failure. And so this is a really rich technique. And we've actually used it with colleagues to kind of ensure that the field of implementation science is buttressed against potential failure points as we think about how to have impact and move the needle equitably in health. Another kind of key design principle is participatory. So you may be in the Q&A, I'm not looking at them yet, be asking questions around how constituents who are in the environments that you're working with are involved about making decisions in how we're changing the choice architecture and what we're prioritizing. And that's mission critical. And I said that at the very beginning of this talk, that implementation science is built upon the premise that this is all going to be deeply embedded, co-created work. And so this is one particular approach that we've used that leans on behavioral economic thinking, which is called an innovation tournament. And so in an innovation tournament, think of American Idol, but for ideas. You crowdsource ideas from frontline constituents who may be thinking about how they could best be supported to implement various evidence-based practices in their context. And then you build your approaches based on what your experts who are actually in the day-to-day tell you versus assuming that we know best what strategies are going to end up in the best optimized behavior change. And so this here is a picture and an example from one of the innovation tournaments that we did with our constituents in the city of Philadelphia. And you can see pictured here clinicians from our system who submitted winning ideas and were celebrated so that we could learn from their expertise. So now I'm going to talk a little bit about clinician nudges. So I'm going to give you an example from a study that my colleague, Dr. Meetha Kurlan, leads. That's focused on implementation of behavioral economic approaches to improve evidence uptake for mechanically ventilated patients in the intensive care unit. So the goal of this study is really to make sure that mechanically ventilated patients receive low tidal volume ventilation to make sure that their lungs are protected while they're under mechanical ventilation. And so in this study, Dr. Kurlan was testing 3 different implementation strategies, all using principles of behavioral economics and through the electronic health record. And there were 2 constituent targets of these behavioral economic implementation strategies. One was 2 of them were targeting physicians, and one was targeting respiratory therapists who set the kind of volumes also when people are mechanically ventilated. And so the idea here, consistent with what I shared with you earlier, is that Dr. Kurlan's study is really trying to make it easier and more desirable for physicians and respiratory therapists to administer low tidal volumes to protect people's lungs without restricting their choice. And so you can see here on the right what the interventions look like, or the implementation strategies. So for the default in the electronic health record, it was auto-populated, so that when a clinician went in to order mechanical ventilation, it automatically included the low volume tidal volume. So it was already set up that way to make it easier to prompt clinicians to do that. The accountable justification condition required a free text justification. So if a clinician went in and changed that auto-populated volume, they just needed to say why they were doing that. And the same for respiratory therapists. So hopefully you can see here now, it's coming to life how we might bring these principles into thinking about prevention and intervention approaches. And you might be thinking about your things and the strategies that you need to test to support people and places in doing your things. And these are principles that really generalize, although these are specific examples. Now I'd like to give you an example of a study that used behavioral economic principles targeting both clinicians and patients with regard to the implementation of an evidence-based practice. So this is work led by Dr. Sam Takvorian and Dr. Ravi Parikh, and this is through our Penn Implementation Science Center and Cancer Control. And the evidence-based practice that we're trying to increase implementation of are serious illness conversations. And I mentioned this earlier on in the presentation. Serious illness conversations elicit patients' care preferences, and there's a good deal of evidence that shows that they improve outcomes and reduce end-of-life healthcare utilization. But most people with cancer die without a serious illness conversation documented in their medical record. So this was a 4-arm pragmatic cluster RCT, and what we were interested in testing were the effectiveness of nudges to just clinicians, just patients, or both, in increasing the frequency of serious illness conversations and the timeliness. And the way we operationalize that is kind of specific to this study. So for clinicians, we sent them peer comparisons on clinician level rates of completing these serious illness conversations, make it social. I'm pulling back in that principle. For the patients, we sent them text messages priming them so that they might think about their care preferences going into the appointment with their oncologist. And then for both, the condition where they received both, they had both the patient and the clinician nudge. And you can see here on the right-hand side, the actual priming message that we sent to patients, as well as the clinician nudge where we gave them peer comparison feedback about their performance. So in this particular study, there were over 4,000 patients engaged across the 4 study arms. One of the things about deploying these approaches within the electronic health record is that you have the opportunity to really do it kind of at scale and to understand the effect of these changes in impacting behavior change. And what we saw is that the arm that had both the patient and the clinician nudge had the greatest completion rate of serious illness conversations. Okay, so now I'm going to share the last study before I close us up, and then there'll be an opportunity for questions. So this is a study that I lead that's funded by the National Institute of Mental Health and builds upon many years of collaborative work with Kaiser Permanente, Colorado, and Henry Ford Health, focused on the implementation of secure firearm storage program in pediatric primary care as a universal suicide prevention strategy. So there was a lot of work that led up to this that I won't be talking about today, but I'm happy to answer in the Q&A. And what we were really interested in answering in this study was whether or not changing the well child visit template in the electronic health record, which is quite low cost and scalable, was enough to change clinician behavior within the context of this particular thing, a brief program to increase secure firearm storage in parents, or if a more intensive and expensive approach coming directly from the implementation science literature, facilitation, was needed to overcome implementation barriers, given that this is a sensitive preventative intervention. And facilitation is an approach that we use in implementation to support clinics in being able to absorb new things or innovations, and includes a range of activities, including audit and feedback, so giving them information on their performance, creating an implementation blueprint, problem solving, barriers that come up when implementing. And so it's a more intensive approach compared to just changing the choice architecture in the electronic health record. So this is a hybrid type 3 effectiveness implementation trial. It's a longitudinal cluster RCT. That's all a lot of words that you may or may not be familiar with, but essentially what this means is that we're looking at both reach as an implementation outcome and parent storage behavior as an effectiveness outcome, but we powered on the implementation component of the study. And there are different hybrids of these effectiveness implementation studies with different foci and subsequent power analyses. So we worked with 30 clinics, 204 clinicians, and this was over the span of a year, and there were almost 50,000 well-child visits in these two health systems that were eligible in this pragmatic trial to receive the thing, which is the secure firearm storage program. In case you're wondering, the thing is basically a brief conversation with the parent about the importance of secure firearm storage and giving a free cable lock. And I'll show you a picture of that in a moment. Those 30 clinics were randomized to 2 conditions. Half the clinics got just the change to the electronic health record and the well-child visit template. The other half of the clinics got that change to the well-child visit template and a year of facilitation. And so our primary outcome is reach, which is the number of children and families who receive the program over the number eligible. And the primary mechanism that we were testing is clinic level adaptive reserve, which is how well it can absorb this thing. The secure firearm storage program, I won't be talking about that. We haven't completed those analyses yet, but just so that you have a sense of our conceptual model. So the program's called Safe Firearm, and the program and implementation strategies included the brief conversation between a clinician and a parent about the importance of secure firearm storage, a parent handout that was given alongside a free firearm cable lock, which you can see pictured here, which is essentially a mechanism that you can place inside of a gun or a firearm to keep it securely stored and to ensure that young people cannot have unauthorized access to that firearm. On the right, you can see how the electronic health record was changed. And you can see that it's slightly different in each health system because it's very important that you integrate within existing workflows. And so we needed to make sure that the way that we made a change to that well-child visit template fit for each of those systems. But essentially a prompt was added for each system in the well-child visit template so that clinicians were prompted to see that they needed to have a conversation around safe storage and to offer a cable lock. Now, these are preliminary findings, and there's a whole lot of people on this call, and so I hesitated to share the results, but we have shared them in conferences. We're writing up the paper right now, but I think it's important to share them with you all so you can kind of understand the power of these approaches, but please don't share them on social media or publicly until the paper is published. So essentially what we found was that patients presenting to clinics that got the change in the electronic health record plus facilitation, the support to the clinics, were 2.2 times more likely to receive the program. So 41% versus 28%. So the clinics who just received the change to the electronic health record only delivered the complete program 28% of the time. I just want to call out, we did get baseline info on program delivery, and program delivery included the conversation and the offer of the locks. At baseline, 3% of clinicians were doing that. So this is really robust practice change, and we're excited about this, and we think that it has implications for national scale up. There's lots of other exciting work in this space that our team and other teams are involved in. I just wanted to kind of whet your appetite and share them with you so that you look out for it. We have a project looking at testing behavioral economic implementation strategies using text messages versus a navigator. So again, that's kind of like that last study I showed you to increase cascade screening for people with familial hypercholesterolemia. We're also focused and working on de-implementation. So this is a trial led by Dr. Chris Bonafide at CHOP and myself, looking at sustainment of de-implementation of pulse oximetry in children hospitalized with bronchiolitis. And there's lots of other projects that we're doing and that hopefully others will be excited to do now that they have a better sense of these methods. And what's most exciting to me is that there's a number of early career investigators who are supported by K Awards who are making this their area of expertise. And I know that they're going to do amazing, even better work than the work that I just shared with you to help us move the needle equitably in health. So I'm going to close us out, and then I see there's lots going on in the chat, so we'll open it up for discussion. But first, I want to just share some concluding thoughts. My first comment is that behavioral economics alone will not be a panacea. So in our world, it is often easy to see something shiny and new and to say that's going to solve all the problems that we have. And I want to be really clear that that's not the case. It's very hard, first of all, to get practice change. We know from the implementation science literature that only about a third of implementations succeed. And so behavior change implementation is exceedingly difficult. And so bringing in behavioral economics isn't going to kind of fix all of that. It's still difficult to have change. Additionally, I think it's really important to call out that many of our contexts that we're hoping to implement within are really struggling. The healthcare context in the kind of acute and peri-COVID phase is very difficult, and we want to make sure that whatever we're doing is not making it worse for clinicians who are really struggling right now. And I mentioned earlier, the insight that led me to this work was really around this idea that we need to make sure that the people that we're serving, that the people that we're working with, that the organizations that we collaborate with have what they need to be able to kind of do this higher order work, if you want to think about Maslow's hierarchy. And finally, I want to encourage us to think about I frame versus S frame. This is a new paper that came out recently by Nick Chatter and Dr. Nick Chatter and Dr. George Lowenstein, really encouraging us to not be kind of fooled by thinking that individual level interventions are going to solve structural woes. We want to make sure that we are matching our approaches to one another. So if something is caused by a structural factor, we need to have a structural level approach. So I'd like to share a couple of other exciting potential directions, and hopefully when it's Q&A time, you'll be sharing some of your thoughts. You know, we've just really begun to kind of go deep on how to incorporate this type of thinking into the existing taxonomies, frameworks, approaches that we have in implementation science. And so there's a lot of work to be done there. As well as thinking about how we optimize these strategies using very thoughtful design and rapid cycle approaches, which are ways to pilot and continuously learn how to optimize and improve our approaches. This is an issue in prevention, intervention science, and implementation science writ large. What works for whom? We know that for a lot of time, our work is focused on average treatment effects. And there's an opportunity in space to be thinking about precision approaches within both implementation and behavioral economics. When to use these approaches in terms of who to be providing these strategies for, patients, clinicians, both. Are there any kind of themes that we're seeing in terms of what's working? And then do these strategies consistently reduce inequities? There's some literature, which I didn't present today, that demonstrates that deploying these electronic health record behavioral economic implementation strategies can actually reduce inequities between populations where there might be an inequity like statin prescribing. Personally, I am a big advocate for thinking about these low-cost, scalable approaches that come from behavioral economics as kind of first-line approaches coupled with other strategies in a stepped fashion. So I think the Aspire trial, the trial I presented that's looking at a nudge versus a nudge plus facilitation, which is more of a kind of clinic level approach, is a good example of my thinking in that space right now. And I'm sure we'll continue to learn so much more about that. And then I've spent most of the talk really focused on how implementation science can benefit from behavioral economics. But I just want to say that it's a bidirectional collaboration. Behavioral economics as a field has started to realize that they've built all of these things that are not necessarily scaling beyond their field trials. And so I actually see it as like a bidirectional arrow that both fields would be much stronger together. There are challenges to applying these concepts. And so I think it's important to call those out as you think about how you might apply them in your own work. Many implementation behaviors are more complex than deciding to prescribe an antibiotic or administer a flu shot. So really understanding the steps in the behavioral repertoire is very important. And a lot of these behaviors require sustained behavior change. And I would say that neither field has kind of hit the nail on the head of how to continue to sustain change. We really want to understand mechanistically what's happening, and many of the things that behavioral economics kind of leverages are implicit thinking processes that can be hard to measure mechanistically. And then finally, this is not a silver bullet. So we still really need to think about partnered work that addresses multi-level factors that might make it hard or easy to implement. Whenever we can, we should bring these behavioral economic approaches in. But it's not going to solve everything. And there's still a lot that we can glean from implementation approaches alongside these low-cost scalable approaches that tend to give us about a 10% kind of increase in desired behavior. So it's a great kind of magnitude of effect for a low-cost scalable approach. But again, to get the most robust practice change, we need both approaches. So I told you I would tell you the main takeaway at the very beginning, which I did. And hopefully now this takeaway is much clearer than it was at the beginning of the talk. I personally believe that the nexus of behavioral economics and implementation science has the potential to transform the seemingly intractable challenge of moving the needle in healthcare equitably. And I hope that you'll reach out to me if you have any questions. And I know that we have a couple of minutes now for Q&A. So I'm going to go ahead and stop share and see if there is an opportunity for questions.
Thank you so much for that wonderful talk, Dr. Bates. Yes, we've had several questions come in. I guess one question, and so the term behavioral economics, it doesn't seem to be mostly focused on, I guess, more on the behavior side and not so much on the economic side. So just curious if you could maybe lend a little bit more intuition into the use of the term behavioral economics.
Yeah, absolutely. And behavioral economics really borrows from a suite of fields, including social psychology, and cognitive psychology, communications. By the way, implementation science does that too. So that's another way how the two fields are different. But really it came about and was called behavioral economics from the work of Richard Thaler, who really helped us understand how these knowable kind of principles and how we think affect our decision making. And many of the early studies had to do kind of with decision making around saving for retirement or various questions that economists ask themselves. But I'm a psychologist, and when I look at behavioral economics, and actually the founders of the field, Kahneman and Tversky, were also psychologists, I see a whole lot of psychology in there.
Great, thanks. I had a question asking if you could speak more on the overlap between implementation science and quality improvement.
Absolutely. That's such a great question. There is a lot of overlap. And it depends on if you're asking about quality improvement, local quality improvement, or improvement science. What I've been very excited about and what gets me up in the morning is that there is now a suite of fields really focused on thinking about how to improve health and healthcare delivery that all kind of fall under this broader tent. So I see improvement scientists using implementation science terminology and vice versa and approaches. And my guess is that in the next 5 to 10 years, they'll align even more. But quality improvement, when we don't put science at the end, is really focused on improving kind of local change. and might not be focused on implementing a particular thing. There's a great paper by Kozawara and colleagues that I'll add to the list of resources that does a great job. There's a table, I think table 1 lays out really nicely kind of some of the similarities and differences. They also come from different kind of origin stories, which shapes kind of the methods that they use, but fundamentally they are focused on a similar target.
Great, thank you very much. One question came in. So one of the strategies, behavioral economics, was to kind of like changing default settings. Had a question about it, asking if you could comment on setting default as the affirmative in the context of consent, like data sharing consent, and when the default is the desired behavior.
So I want to make sure I understand the question. So the question is about whether or not we should make it the default that we share data.
I think it's setting the default as like the desired behavior. So it seemed perhaps the question asker could, if they want to speak again, to clarify. But I guess the way I read it was the setting default as the affirmative in context of consent. For example, data sharing consent, when that is the desired behavior. Is it acceptable to default consent?
Well, that's a much different, that's a big question. That's a big ethical question. I think within the context of kind of pragmatic trials having an opt-out consent, there's certainly many studies who use that. But it also, data sharing is different than potentially consenting to a study. I guess what I'll say about that is, yes, there are ways to use these principles to set defaults for various desired behaviors, but how you define what the desired behavior, whether it's ethical, whether you should do that, is a big question that has to guide the start of this work. And that's why it's really important to have all constituents' perspective represented, and to have regulatory and monitoring boards to make sure that the decisions that are being made are in the best interest of all parties involved. So hopefully that answers the question.
Thanks. Had a question about what the literature might say about the sustainability of effects from nudge implementation strategies. You have any comment on that?
Yeah, that literature is still growing. So there isn't like a definitive finding I can point to. We are actually in our Aspire trial measuring that exact question, and we'll be able to tell you all in the future whether or not the effects of the nudge continue on after facilitation is removed. We're measuring that for a year. The only thing I'm going to say, and this I'm actually borrowing from a colleague here, Dr. Kevin Volpe, is that I think sometimes we hold behavioral strategies to a different kind of bar than we do for like pharmaceutical interventions. Like, we wouldn't expect that someone's blood pressure would stay low if they stop taking their medication. And so when we're doing these types of studies and we withdraw a nudge and then we see the behavior go back to the way that it was, I think that's to be expected. But I do think there are important questions about whether or not people habituate to nudges and then stop engaging in the desired behavior. And I'm also really interested in this question of how different nudges within a broader system might interact with one another. So you could imagine a clinician working within a service line where there's a number of different nudges coming their way and that potentially having a negative effect. I don't think we've really answered the question to that at this point, answer that question. But the only other thing I'll say is that well-designed nudges are meant to not be experienced. And we are, you're in choice architecture, whether or not it's designed. So if you're in an electronic health record, it's been designed some way. And so we might as well be thoughtful and bring these principles, as long as, again, we're bringing along all the constituents who are a part of experiencing that environment to make sure that it's optimizing and, shaping behavior in the way that is intended.
Thank you very much. I think we might have time for one more question. So this is a very interesting area of study. If one was interested in getting more training in implementation science, what resources might you suggest?
I will absolutely provide some of those in the materials. There's so many resources that I can't possibly do it justice in the 30 seconds that I have, but I will put out a plug The NIH Academy Health Dissemination and Implementation Conference actually starts this Sunday and is an annual conference where people from all around the world come and share work that they're doing in implementation science. And there's a growing number of folks doing work at this intersection. So that would be a great place. But there's also some websites that list different training opportunities that people can seek out if they're interested in these areas.
Great. Thank you so much, Dr. Bates. And thank you to everyone who participated in today's webinar. On the Mind the Gap website, prevention.nih.gov/mindthegap, you'll find several resources for this talk, including the slides and a list of references. We will also be posting a recording of today's webinar on our website in a few weeks. Thank you and have a great rest of your day.